Good afternoon. I see a lot of people are starting to log in now, so we're just going to give it a few minutes before we get started. But welcome. We're delighted you were able to join us today. For those of you who are just joining, good afternoon and welcome. We're delighted you were able to join us. We're just going to give it another minute or two as we have a number of people who are still logging on to the town hall. It was great. You can see the numbers just sort of going up. So I'm keeping an eye on that before we get started. So. Right. So in the interest of time, because we just have the hour for our town hall today, I will get started now. My name is Mark Graham. I'm the Vice President of Program Services at Coordinated Behavioral Care. We're really happy to be able to host this webinar today for our workforce and to be able to respond to questions that have been posed by our workforce and to offer answers and perhaps some solutions as well. To give you a little context and a sort of understanding of where the idea for this town hall came from, CBC were approached in late December by one of our member agencies who had been consulting and talking with their frontline staff and were receiving questions that were really sort of important to their workforce, but that they didn't feel well versed enough to respond to. And they asked if CBC perhaps knew someone who would be an expert in the field around COVID and would be able to respond to the questions that their workforce had. And then over like a couple of days after that first conversation, as we looked around for someone who could provide that expert guidance, we were approached by a number of different agencies who were asking sort of similar questions and saying like, you know, given your knowledge, where would be the best place to go? How could we support our workforce around COVID-related questions? And so we were able to identify, and I'm going to welcome Dr. Trivedi and thank her for her time today. And she works in the area of infectious diseases and has done a lot of work around COVID, and I will allow her to sort of give her own bio in a way. But we approached her and we were able to talk about our workforce in New York City and the work that they do in the behavioral health field. And she felt that she would be able to sort of respond to the questions that were posed and agreed to join us today. So welcome. And perhaps if you'd like to give a little bit of sort of an overview of your own background. And then I believe you're going to give us a little bit just of a sense of where COVID is today in the United States and particularly in the New York City region. And before we jump into some questions that have been posed to us by members of our workforce. So again, thank you.
Great, thanks, Mark. Thank you all for joining. My name is Kavita Trivedi, and I am a physician epidemiologist. My training is both with the Centers for Disease Control and Prevention in Atlanta, as well as at the State Health Department here in California, where I'm based. And over the last 10 months, I've had the pleasure of consulting with a variety of organizations and businesses around the country, really helping everyone to understand the evolving science around COVID-19 and how we can appropriately respond to what's going on around us, how we can still do our jobs, live our lives in the context of the pandemic. So I've been working with lots of different organizations, and I'm really excited to bring some of my guidance to the discussion that we're going to have today.
Excellent. I think you're going to pull up a slide or two, but I just wanted to sort of add to that. It is a discussion today, and it's really a sort of a question and answer session. And the questions that sort of I have been given are questions that have come from our member agencies. So as I mentioned, we were approached by one or two, and they talked to their workforce and then submitted to us questions that came directly from their workforce. And they're sort of the areas, and it covers a lot of topics, everything from travel to PPEs, and now a lot around vaccines. but also this is an interactive town hall. So please use the chat box to ask questions as we go through, and the doctor will take those questions as well as we go through our discussion today. So the chat box is there for you, and I will do a reminder as we go through the town hall. So.
Great. Okay, Mark. So I'm going to start off with just some slides as to where we are right now in the pandemic. So this is the epidemic curve, according to the Centers for Disease Control and Prevention as of this morning. And as you all very well know, especially in New York City, we had our first surge back in March and April. And we are now in a third surge, if you will. And you can see from the epidemic curve, so each of these blue bars represents new cases on each day. And we are clearly in actually the worst part of the pandemic right now at this very moment. So we've had the most cases identified just in the last few weeks. So worldwide, we have now 92 million confirmed cases with close to 2 million deaths. And this is data from at least 191 countries all over the world. In the United States, we are close to 23 million confirmed cases, with closing in on almost 400,000 deaths in all 50 states and our 4 US territories. A couple of sobering numbers that are probably not that accurate, actually. This also is data that comes from the Centers for Disease Control and Prevention, but there are 354,000 healthcare personnel that have been confirmed with COVID-19, with just around 1,200 deaths within the healthcare personnel space as well. So even amongst people who have appropriate PPE, we are still unfortunately seeing deaths and cases occurring within healthcare institutions. And like I said, we don't think this data is actually entirely accurate. The numbers are probably a little higher. As you all know, the nursing homes in the United States have had a really large brunt of of both the cases and the deaths, where over 40% of deaths are occurring in the nursing home population. So thus far, I think this data is from CMS through the end of December. We've had 97,000 deaths within US nursing homes. And I just want you to remember that we have many, many people across the country who have symptoms of COVID-19, but have not been tested, or their test results are a false negative. So these numbers are likely much lower than the real numbers. So just take a minute to understand that these numbers look really high, but they're probably even higher than we actually recognize. This is a map showing where the cases are currently high across the country. So gray would be no cases. And the dark red color is essentially a lot of cases. So we can see that, as opposed to earlier in the pandemic during the first surge, where New York had a large number of cases, we now see hotspots across the country. So we have these dark red spots in Los Angeles and Oklahoma and Arizona and Texas and New York and North Carolina, and we have them all over the country. And this is obviously really stressing our healthcare system, where we have many hospitals that are now full, that are really busting at the seams in terms of space, but also from a staffing perspective, right? We only have a certain number of healthcare providers that can provide care to all of these patients, not to mention all the patients that are still having heart attacks and strokes and pneumonias that are not related to COVID-19. So this is truly stressing our entire healthcare infrastructure throughout the United States. So what's happening in New York State specifically? Again, as of this morning, this is data both from the New York Times as well as the Washington Post, showing that cases are are elevated. As of yesterday, there were close to 15,000 new cases reported in New York State. And you can see that compared to the March and April surge, we have more cases occurring now than we did back during the surge. And if you look at the 14-day change in cases, it's continuing to go up, deaths are continuing to go up, and hospitalizations are continuing to go up. And you can see from the right side of the slide that there are certain counties that are hotter, if you will, that have more cases, but essentially we have a large number of cases occurring all across New York State right now.
So I saw these slides yesterday, and the numbers and the coloring in a way, it's very sobering, and especially at a time when I think the vaccine, and we have questions in relation to the vaccine, and perhaps people are feeling more hope. It's still startling, the number of cases, and one of the questions that sort of came through was in relation to New York City in particular. And I think it brings it down to the level of people who are still going out to work. Like, how safe is our subway system? We're a city where more people are using public transport than other parts of the country. And several questions came in relation to our subway. And I was wondering if you'd be able to speak to that, and if there's been any data about catching COVID-19 in the New York City subways.
Yes, great question. So I want to start off this part of my response, Mark, that might take a few minutes, on this concept of Swiss cheese. So I have an image here of multiple layers of Swiss cheese. So you all know probably that Swiss cheese has holes in it, right? And the idea is that we place, we place interventions or layers of Swiss cheese between us. So we're over here, we're the green person, and the virus. This is the virus over here. So we want to layer different interventions, which are different layers of Swiss cheese. We know each intervention may be imperfect, they have holes, but the idea is that you layer it in such a way that the virus cannot get through all of these holes because they're not in alignment all the way to us. Okay, so that's the first kind of fundamental thing to understand about the way we are talking about interventions from the public health space. So the pillars of prevention that we really want to focus on are face coverings, right? Physical distancing, staying home when you're ill or you're exposed. And this one is really important. And I repeatedly see people not following this, right? They have to go to work. So they still go to work even if they're not feeling good. Consistent hand hygiene and cleaning and disinfecting high touch surfaces. So I just want to spend a moment on the first two, which I think are the most important. Again, the most important layers of Swiss cheese. Face coverings, especially important indoors because you're wanting to reduce the amount of droplets in the environment. So that's called source control. We also know that wearing face coverings protect us, the person wearing the face covering, because it decreases the amount of viral load that you're exposed to from other people. So two reasons why face coverings are really important. And I'll get into that in a little more detail in a moment. Physical distancing, decreasing contact time if you're within 6 feet. And the reason we do this is for barrier control. So we talk about source control, decreasing the amount of virus in the environment. And then we don't want the virus to be able to travel that far. So we implement these barriers. So I just want to kind of start the discussion with understanding the pillars of prevention and these layers of Swiss cheese, okay? Now, again, face coverings, physical distancing, the most important pillars of prevention, but staying home when you're ill or exposed, washing your hands are all important things we can do. So face coverings, let's talk about face coverings for one moment. Again, a little more depth. In an indoor space, we really want to consider a cloth mask at least. And if you are unable, like in a subway, you're not able to maintain that 6 feet of distance with other people, you can also consider a face shield to help you with barrier control. Okay, so again, masks, especially indoors, subway would be considered one of these indoor environments, and then face shields if you feel that you cannot maintain the 6 feet of distance. Now, in a couple of really great case studies, we have noted that face coverings alone can prevent transmission of this virus. So there's this really famous situation with two hairstylists in Missouri that you may have heard about. This was back in May, where both hairstylists who happened to be ill but did not know it yet were, and they were symptomatic as well. They actually cut the hair of 140 clients in a town in Missouri. They wore masks. All of their clients wore masks. No one became positive that we know of out of this situation. So remember, they were not physically distanced, because when you cut someone's hair, you obviously can't be 6 feet from them. But the client and the hairstylist was wearing a mask. And because of that, there was no transmission that we were made aware of. So face masks absolutely work. Now, the other question people ask me about face coverings are, which is the best mask for me to use, right? Which one should I focus on? Well, my first answer to this is the best mask is the one that you do not touch after you leave your home, right? So the people that keep moving their face mask off their face because they can't breathe, they take it off one ear, they move it off their nose. That's not the kind of face mask I want you to wear. I want you to wear a face mask where you can keep it on your face, you can do what you need to do and not touch your face mask. That is the most effective face mask. Then we're starting to talk about which face masks are the most effective for a particular situation. So if you're going indoors, maybe you want to think about a higher filtration mask. You want to think about a surgical mask, maybe. If you were going on a walk in the neighborhood, maybe in that situation, you want to think of more of a cloth mask that is not as form-fitting. So we're starting to talk about maybe which activities warrant which type of face masks. And I have a little hierarchy here that I've put together, again, based on science. So obviously an N95 that's fitted to your face is probably the best in terms of preventing transmission. Not all of us can wear that all the time, and we shouldn't. And then there's the form-fitting surgical mask, so the surgical masks that people often get at work. Those are great, but they can be very loose on the sides. So a way to make it form-fitting would be either to wear a brace kind of over a surgical mask to help make it more form-fitting around your face. Or even there have been studies done on nylon sleeves around surgical masks where you actually cut pantyhose and you put it around the surgical mask. So that way it actually is form-fitting to your face. Loose-fitting surgical masks are probably the next best. Then we get into the cloth masks, the neck gaiters, and of course the worst thing is to wear nothing.
But there's also the one with the little thing on it, which when I first saw, I thought, wow, they're the advanced masks. And then I learned later that they're not. So
no. So yeah, so right. So I think you're talking about, Mark, the valves. Yeah. So some masks have little valves on them. So those masks we do not want people to wear, because those masks actually cause whatever you're breathing in to be pushed out into the outdoor environment. So those are the masks that people wear when they're doing construction, when there is a fire in the and they don't want to breathe in what's outside in the air, the particles in the air. So those are actually not the masks that we want people to wear in the context of the pandemic. Okay. Now you asked me about subways, so I'm getting to that slowly. So this is a nice chart, which was a simulation study looking at masking and distancing. So I just want to walk you through this just for a minute. So if you are wearing no mask and you're only a foot away from somebody who has COVID, you are probably going to get the COVID. Your risk is extremely high. If you're 3 feet away, oh, sorry.
The one for curiosity, how much time am I spending with that person? So if it's, again, walking past someone on the street, or very briefly, my security or, guard in my office, I'm probably fine, right? It's if I 10 minutes is just to put the time in there.
So the understanding is that contact time is greater than 10 to 15 minutes of being with this person. So thanks for that clarification, but that is true. So yeah, 1 foot of distance, again, being with that person for 10 to 15 minutes without a mask, your exposure risk is essentially 100%. If you increase that distance to 3 feet and have no mask, in this simulation study, the exposure risk dropped significantly, dropped to 17%. So you dropped your risk of getting COVID by almost, 83%, right? Or sorry, 73%. I can't subtract. 6 feet of distance. If you have 6 feet of distance and no mask, that also decreases your risk of exposure down to 3%. So this is where the 6 feet of distance comes from when we've done these kind of simulation studies. Now, I just want to walk through the other things. So source mask, that means if you are the person who unknowingly has COVID, right? You're the person with active COVID. If you mask yourself in any of these situations, the exposure risk drops significantly. So if you're 1 foot, 3 feet, or 6 feet away from the person who has COVID, you've dropped your risk of transmitting the virus by a lot. So this is really important. If you yourself have COVID, you must wear a mask, even in your home, to prevent other people in your home from getting the virus. And then if you're the person who doesn't have COVID, but you are susceptible to COVID, the more distance you put in between you and the person who has COVID, the more your exposure risk drops. So in the setting of being 1 foot away from that person, 38 to 39%, you go 3 feet, now you've dropped to 7 to 6%. You go 6 feet, you've dropped 1 to 2%, right? And then the best case scenario is when both people are masked and you maintain distance. If you look at the bottom row here, you've decreased your exposure risk by you're now less than 0.5% away in terms of risk. Okay. So we want to do both the masks and physical distancing. Masking is probably more important, but we'd like you to be 6 feet away from people.
Okay, just to interrupt for 1 sec.
Yep.
Came up with your last slide there.
Yes.
And I know we will get the vaccines, but people are asking if they have been vaccinated, does this all change? I know there's still recommendation to continue wearing a mask, but do all the distancing, like if I'm vaccinated, am I good?
Yeah. So, if you're vaccinated, and other people that you're around are also vaccinated, the discussion is that you can probably act completely normal with other people that are also vaccinated. Mm-hmm. The problem is that children are not being offered the vaccine yet because we don't have a vaccine that's yet been tested in children and proven to be effective. And we're having a relatively, slower rollout of the vaccine that we want to have. So for the time being, public health professionals are recommending that even if you're vaccinated, when you interact with people that are not vaccinated, we'd recommend you wearing a mask and maintaining distance. Because there is still a chance that even though you may not have the virus or you may not have the infection, you could have the virus in your nose and you could transmit it to somebody else. So it's still important for the time being. And we can get into this later as well, but for the time being, we would recommend people who are fully vaccinated to still wear a mask and keep distance from other people that are not vaccinated.
Cool. Thank you for that. And just so you know, there are chat questions coming in. I will get to them. So as they're coming in, but to go on back to the subway then a little bit.
Yes,
so
sorry, let me get to my subway slide. Where is it? Oh, here it's under travel. Okay. So to date, there is no evidence of transmission occurring frequently on public transportation like subways and buses. And my colleague Brad Hutton, who's on the call as well, was kind enough to share this information with me. One recent review was undertaken by the transit industry that found while the people that rode transit increased from June to August of last year, infection rates in those cities actually declined in those same cities. So we do not believe that public transportation is necessarily the reason that rates are going up. Public transportation often uses enhanced cleaning and disinfection. They've been pretty good about limiting capacity on these buses, subways and buses, and they do require mask use. And also ask riders to be vigilant about hand hygiene. So we do think that you can ride public transportation safely. So from my perspective, let me give you a couple of hints or guidelines about what you might do to feel safe in the subway. Think about purchasing your tickets online, so you're not doing that at the subway station itself. You may, you definitely want to self-screen for symptoms. You do not want to travel the subway if you have any symptoms yourself, or if you've been exposed to somebody with COVID-19. Again, you want to wear that face covering that's comfortable so you don't need to touch it. You want to keep at least 6 feet from those people on the subway that are not in your household. And if you can't, you might consider wearing a face shield, again, to help maintain that barrier control. You want to avoid touching your eyes, nose, and your mouth. I like to have some hand sanitizer in my pocket so I can sanitize my hands frequently. And then the last thing I just want to say is that gloves are not recommended. We think when you wear gloves, then that allows you to touch more things, and you may actually be contaminating multiple things while you're wearing gloves. So we'd rather you have hand sanitizer that you can actually use to continually wash your hands when you're touching something, you know, that could be contaminated potentially.
And just to add to your transit thing there, changing trains.
Yep.
Like someone had asked, is it better to stay on one train all the way down, or is it better to switch trains, come off the platform and stuff? Any recommendation on that?
Yeah, I mean, I think, remember, the contact time is still that 10 to 15 minutes. So usually you're not sitting on the subway with other people for that period of time. There's a lot of movement of people going in and out. But if you do feel that you're meeting that contact time, again, this is the situation what I would recommend a face shield, because with the mask and the face shield, you are both decreasing the amount of virus that is coming into any of your mouth, your nose, and you're also preventing it from coming into your eyes, which is also another place where the virus can enter your body. So, you know, again, based on the data and based on these recommendations that I'm giving you, we think that people can ride the subway and be relatively safe.
Mm-hmm. We are getting a little sort of question. Someone did raise a point that they were often on the subway for people for longer than that 10 minutes. And certainly I have been too, if you're commuting down from the Bronx into Manhattan or stuff. And something you had said to me on, we had a pre-call, was the ability to control yourself within the subway system. So there is always that ability to move carriages if you're towards someone who you're concerned maybe isn't wearing a mask, or someone who is sneezing or something like that. You can still control your environment within the subway system by leaving that train or moving to a different carriage. So I just wanted to acknowledge that comment. And with that as well, a question I thought was very interesting was, what's safer, Uber or the subway?
Mm-hmm. So I don't know. We certainly have not had any head-to-head studies to say what's safer than the other, but I would say that there are also some nice recommendations that we've developed on what you can do to ride the Uber or ride in a taxi, and also try to maintain some distance from the person who's driving. So you want to sit in the back of the vehicle. You can also ask the driver to not be on the recirculation mode, so that the air is recirculating in the taxi or in the ride share. So you can easily just open the windows, but if it happens to be really hot or really cold, you could ask them just to make sure that they're getting air from the outdoors rather than recirculating air within the ride share. But again, in this situation, a mask and then certainly a face shield if you're not able to maintain that 6 feet of distance. So I would keep these things on me at all times. I mean, you should be wearing a face mask anyway, but I would be keeping the face shield around me and hand sanitizer in case you need them, right? In case you need those things either in the subway or in the ride share.
Very good. I think just to move on to sort of an area that comes with that, a lot of our staff are in the field. So they're working and they're going to their office or they're going through the subway and stuff. And if they're returning home, even with or without someone who's medically frail within their family home, do you have recommendations for what to do? I remember at the beginning, people were taking their clothes off. My parents would leave their shoes outside or put plastic bags on their shoes and stuff. Is there sort of guidelines or recommendations for what to do when you get home from work?
Yeah. So I think this goes back to how this virus is transmitted. So the main way that this virus is transmitted is person to person via respiratory droplets. These droplets get into your eyes, your nose, and your mouth. And I want to emphasize eyes, because I think that has not been emphasized. People are really pretty good about covering their nose, not as good as covering their mouth, and certainly not good at covering their eyes. So just remember, this is the main mode of transmission of this virus. Now, aerosols can remain in the air for some period of time, but fomites, which is, these are objects that harbor the contaminated saliva. We haven't seen many instances where fomites were the method of transmission. So early on, we told people to wash all their vegetables and their fruit and to keep their Amazon boxes outside and not touch them for 48 hours. We now know that these objects are really not the way that the virus is transmitted. So we're not asking people to focus on that. We really want people to focus on this first point, the virus spreading person to person. So the things that I just want to note about this is that, environmental contamination can happen. So remember early on, we had all those studies that said, oh, the virus is still viable on cardboard for a certain period of time, or glass or copper, or these different types of metals, right? So even if we have these studies that show us the virus is viable on certain surfaces, and certainly if you have a client who has COVID-19, the surfaces in their room are most likely have viable virus on them. But just because there is virus on those surfaces, it doesn't necessarily mean that there's an infectious dose of virus in the air or on that surface. So again, surface is less important. I think the thing that we are focused on, though, is ventilation. We do think that crowded spaces that are poorly ventilated, such as the elevator, there is a risk of transmission because the virus can be potentially in the air. So what I focus on now, after I go see patients in the hospital, is I really focus on the mask. So the mask, again, is where the virus could be on top of. So what I really wanted to just highlight for this response, Mark, is, make sure you wash your hands, make sure you take off your mask appropriately, make sure you discard your mask in the right place, because that's really what we want to focus on in terms of what could be contaminated and what could, if you touch the outside of your mask and then rub your eyes, that is a perfectly adequate way of transmitting the virus from your mask to your eyes. So that's really what I want people to focus on. You don't need to wash all your clothes or do all that. Just be really cognizant, especially of the mask and where your hands have been, and washing them before you touch your body.
And just what somebody said there, which struck me, was about the eyes, because I'm not as aware of that. And someone put a question in the chat about regular glasses, like glasses you're wearing now. Do they help prevent transmission?
Yeah, so there were a couple of studies that were published a month or two ago, which showed that if you were wearing glasses, the risk of transmission might be a little lower than people who don't wear glasses. But in the hospital, and in any healthcare environment, we do see people wearing goggles that covers, as opposed to these glasses, right? Cover the sides of your eyes. And then remember the face shield. The face shields actually protect you from, well, the face shields do a couple of things. And I don't know if I have a picture of me. I think I tried to put a picture of me with a face shield in here. So you guys, oh, here's me. So with prescription sunglasses on. I don't know why that happened, but so you can see with this face shield, it's actually difficult to touch your eyes and to adjust your face mask with a face shield on. You have to get your hand underneath the face shield and do this kind of thing, which is actually quite difficult. So the face shield does a really good job of preventing the person wearing it from touching their face mask, as well as touching their eyes. So the face shield does a number of things of protecting your eyes, your nose, and your mouth, as well as not futzing with the face mask, as I mentioned earlier.
Yeah. Can I just with the face shield, I don't see as many of those around. Where do I get one? Is it an Amazon product? And what about the cleaning of that? Because I'm a touchy person with my fingers. So right. Just curious.
So the great thing about face shields, and I know that there are some organizations in the mental health behavioral care space that are getting these for their employees, but You can buy them on Amazon. They're not that expensive, and you only need one because you can wipe it down each day and reuse it again. So the way I would wipe this down is I would use some sort of disinfectant that is active against SARS-CoV-2 and the virus that causes COVID-19. So this can be an alcohol-based wipe. This can be Lysol, Clorox, any of those kind of that are listed on the EPA disinfectant list. You can use any of those to wipe it down and then reuse it the next day. So it's totally fine to touch it, but you do want to clean it after you have potentially been on the subway or been in an indoor space. You do want to clean it before you use it the next time.
It's great. I'm already realizing our 1 hour it's not going to be enough. There's some great questions coming in, but I do want to sort of like shift to some more of the questions that I sort of received in advance and then come back to those. And we'll certainly leave at least 10 minutes at the end for more of those Q&As. So keep the questions coming, and anything that we don't get to, we will find an answer afterwards and be able to send that out. But at the moment, like, news changes all the time with COVID, and it's now vaccines. And I've heard so many different reports on different stuff. And I'm just curious, like, you're a doctor, like, are the vaccines safe? Because I've heard a lot of concerns from neighbors of mine and friends and people who are not sure whether it's safe to take.
Yes. So I have a few slides on this. So firstly, this is the approval process for, and my state, I was trying to cover up California, but it moved. So this is the approval process for vaccines. And when you're in the middle of a pandemic, we have a fast track process for how you have vaccines approved. Mm-hmm. So what I want this slide to highlight is that they're independent experts that are involved at every step of the way to evaluate the vaccine. So there's this first data and safety monitoring board, which reviews safety and efficacy of the data that's coming out of the last phase of the trials. Then there are independent vaccine advisory boards that are committees within outside of the FDA, that the FDA asks to look at the data again. They do their reviews as well. Then career scientists from the FDA also review data. And then finally, what's happened, at least with COVID-19, is each state has found independent experts within the state, a group of scientists, public health experts, who then review all of the safety and efficacy data before they distribute within their state. So there are multiple levels of oversight that have happened. And just because we're in the middle of a pandemic, we haven't skipped over any of those steps. So I think that's really important to know. Then the other thing that happens is the CDC has an advisory group, the Advisory Committee on Immunization Practices, that also reviews the data at the same time that these independent experts are reviewing the data as well. And then they also make recommendations. So these vaccines have only been approved for use in the population after all of these steps have occurred, okay? Mm-hmm. So this is the status of the 5 leading COVID-19 vaccines in the US right now. The 2 that are currently available are the Pfizer vaccine and the Mrna vaccine, right? Those are the 2 that are currently being distributed to healthcare workers in every state across the country. Now, both of these vaccines are mRNA vaccines. And I just want to take a second to talk about what mRNA vaccines, what that means, because this is actually a newer technology that we have not used before. So mRNA technology causes cells to produce the spike protein and elicit a protective immune response. So what has happened is there's a message, actually I have this here. There's a message that is sent to the body. This is what the spike protein looks like. And then the body develops an immune response to that spike protein, but that initial message is actually destroyed. So I really like this from Dr. Tom Frieden, the previous director of the CDC, who says an mRNA vaccine doesn't actually contain the virus itself. So this is important because I think I hear a lot of people saying, I don't want to take, I don't want to have the virus in my body, right? This vaccine does not have the virus in it. Think of it as an email sent to your immune system that shows what the virus looks like, instructions on how to kill it, and then, for you millennials, like a Snapchat message, it disappears. So that literally is what we're doing with mRNA technology, and that is the type of technology that is incorporated into both the vaccines that are currently available.
And why 2 stages to it though? Like I get the flu shot, it's one done. So why is there this like 4 weeks later I need to go back?
Yes. So, so I have a slide on here. Let me actually try to get to it real quick. So, okay. So this down here at the bottom of the screen shows you the 2 graphs that the Pfizer vaccine and the Mrna vaccine trials, the phase 3 trials produced. And what you see is that, okay, so the flat line on both of the graphs, unfortunately the colors are flipped, so I can't just call them one color, but the bottom line is the group of people who received the vaccine. So the blue line and the Pfizer, the blue flat line in the Pfizer group are the group of people in this trial that received the vaccine. The Mrna one is the flat red line on the bottom. So they were followed for symptoms, who developed symptoms, and then those people were tested. So none of, really very few of the people in the Pfizer group and the Mrna group, as you can see, basically none of them received or developed COVID-19. However, if you look at the group of people in the placebo group, so the arm that they were using to compare, that's the red line in the Pfizer graph and the blue line in the Mrna graph, you see that number, the number of people that had COVID-19 goes up, right? Yeah. So from this, we know that there is very high efficacy of getting the vaccine and not developing the infection. We know that. And that's why Eric Topol, who is the editor of Medscape, he says here that, you know, these are the most important clinical trials in our lifetime, with these 74,000 participants in both of these trials that are classics. I mean, this is really what you want to see out of a vaccine trial that shows you really have prevented the infection from occurring in the group of people that received the vaccine.
But just someone who's non-medical, it's still, to me, it seems like, wow, this is really fast. Like, you know, how did they, you know, get to this stage? And are there categories of risk? So we had a question here in the chat, like, if you have allergies, is the vaccine counter indicated?
Right.
And what type of allergies are the most of particular concern? Like, that's all, you know, I mean, bringing some of this, like, this out, so like to that sort of allergies question, do they know? Should people be concerned?
Yes. So let me answer your first question first, like how this all happened really fast. So I think that the answer to that is that yes, it happened fast, but it happened fast because of the science that is already, because of the advances in science over the last 20 years. So this is a timeline of how we got to this point so quickly, right? So December 1st, the COVID-19 illness was documented. January 10th, so before many people in New York City even knew that this virus existed, we already sequenced it. We already sequenced the virus January 10th. January 15th, which is, you know, a year from this Friday, January 15th, the NIH had already designed the mRNA vaccine in collaboration with Moderna. So already, just a year ago, we have the advance of, you know, genomic sequencing that has occurred over the last 20 years. We have the advance of mRNA vaccine technology, which has been developing over the last 20 years. So all of this science was able to be funneled into the development of these vaccines. So although it appears fast to the layperson, this was not fast. This was built on the fact that we had science kind of helping us over the last 20 years. Yeah. And then in terms of the safety profile, so there are some short-term mild to moderate pain. Oh, wait, you know what? I didn't answer the other question too, Mark. There is a lot to talk about. But in terms of the safety profile, there are short-term mild to moderate pain at the injection site that we have found. The most common side effect after the vaccine is to have fatigue and to have headache. And it's more common after the second dose. So you asked me earlier, why do we need 2 doses? Because in the trial, they noted that you only have a 50% efficacy after the first dose, and you go up to that 95% efficacy after the second dose. So you really do need both doses to have an adequate immune response for you to be able to be normal with other people that are vaccinated, right? So the safety profile, the headache and the fatigue were more common after the second dose, and also more common in younger recipients. So if you were 16 to 55 years of age, you were more likely to have one of these side effects. Now, in terms of serious adverse events, we saw relatively few of them in the vaccine arm and the placebo arm in both the Pfizer and the Moderna trials. What we noted is that we did have some things like Bell's palsy occur in the vaccine arm, but not at a higher frequency than we usually find in the normal population. So remember, we're still going to have normal things happen, heart attacks, strokes, these things are going to happen. They're not necessarily related to the vaccine. And then the last thing I just want to say is that anaphylaxis, so that's when you have a severe allergic response. We have seen that in 21 patients, I believe, in the Pfizer trial. So it's only 11 people per 1 million doses administered is what the rate is, which is like 0.0001% of people have anaphylaxis. And in order to combat this, what is happening is you are watched for at least 15 minutes. If you have a history of allergy, but actually, no, sorry. You are watched for 15 minutes regardless to make sure that anaphylaxis does not happen. So you can have that addressed right away. And most of the people that are getting anaphylaxis have a history of prior allergy. Right. And then the other thing, I think you asked about underlying medical conditions. You asked about underlying medical conditions, right?
Yes, I did. I was just wondering with those, and someone has come in here as well, just about if people have had shots before and get the arm pain, like when I have the flu shot and stuff like that, I often get a stiff arm. Are they more likely to get it than someone else? So
yeah, so the arm pain, some of the pain is your body showing you that it's building the immune response. So we actually want you to have some sort of effect, so you know that your body is building the antibody. So having a sore arm is not uncommon, but that does resolve after 24 to 48 hours, having that sore arm. And that again is your body building the antibodies that you want it to build to fight off the virus. So we actually welcome those type of side effect profiles. And then in terms of people with underlying medical conditions, so they were not included in the trial, but unless there are other contraindications, we are recommending that people with HIV, people with immunocompromising conditions, or even people who take immunosuppressive medications do consider taking the vaccine because they are at increased risk for developing severe COVID-19. And this is also the same for pregnant women. Pregnant women, there is no safety data as of yet, very clear safety data on these particular vaccines in pregnant women, but we have had women who have become pregnant in the vaccine trial. And we've also not seen any adverse events because of the vaccine with them. Remember, we're giving them that kind of that message on how to produce the immune response, how to produce the antibodies, and then that data goes away. So because these are not live viruses, we do not believe that people with these immunocompromising conditions or pregnancy should be at any higher risk than any of the rest of us.
I want to get to a few more of the questions and maybe sort of a rapid fire back and forth a little bit. But and this question I've thought about myself: how long does the vaccine actually last in our bodies? Like, is it once a year like the flu, or are we good once we get it once?
Yeah, so we don't entirely know yet. We do have data that some people who get the infection, that they have antibodies in their system for up to 8 months after they have the infection itself. So our hope is that this is something that we get either at a frequency of 6 months or at a frequency of 5 years. We're not quite entirely sure about where we land in that span yet. But there's a lot of scientific research going into figuring out that now. And I think the other thing is these variants that we're seeing, these different strains we're seeing, we have to ensure that the vaccines we have available are efficacious against those variants. And if they're not, then we will have to consider getting another, booster, another vaccine with the correct strain. But it doesn't appear that is a problem as of yet. It's just something to think about in terms of the future. So I don't have a firm answer to that question quite yet.
I think just for everyone's sake, I mean, we all know that information is changing all the time and is rapid. So, we're learning a lot. And in 2 weeks' time, we could probably giving different answers to some of these questions.
Right.
And one is that something that's come up is like, what percentage of the population actually needs to be vaccinated before it's kind of like safe for us to either drop our masks or return to doing more gatherings with friends and stuff like that. Like the hope that we all have, I suppose.
Right. So we'd like to achieve kind of herd immunity or community immunity, which is probably around 70% of a population that needs to be vaccinated. And I'll just remind you that, the Moderna and the Moderna and Pfizer vaccines are only being allowed to be given in adults over the age of 16 as of yet. So we have a whole chunk of the population that we are not able to vaccinate, right? As of this moment. So if you assume that the US population is around 329 million people, then herd immunity, we get there with 230 million people vaccinated. And I will also offer that I think different communities will have and are already having different rates of vaccinations. So some communities may reach that 70% threshold before others. So that's really what we're looking for. And I think in the meantime, we need to consider the fact that we still need to wear the face masks and physical distance and do all the things that we have done before. This is a colleague of mine, an ER doctor in New York City, who says about a month ago, tomorrow I get vaccinated against COVID-19. You know what I'm going to do right after? I'm going to wear a mask. I'll take the exact same precautions that have kept me safe for months in the ER and in public. And I'm going to essentially act as if I'm not vaccinated, but I will be really grateful. So I think, what we still want people to do is stay home if you're sick, wear a face covering, physically distance, keep your hands clean. And, hopefully we get to that herd immunity quickly and we can start stripping away some of those layers of Swiss cheese.
So for our workforce, just a quick question. Something comes up when we work with people with severe mental illness, and if someone you go to see in the community refuses to wear a mask when you're in their presence, but yet needs your intervention, maybe it's the nurse giving an IM and stuff like that. Like, do you have any guidance about like how best to approach asking someone to wear a mask or bringing your own supplies for people? I just wondered if you've come across it yourself.
Yeah. So I think that it's important for us to have obviously be role modeling appropriate behavior ourselves. So you need to wear a face covering at all times and not be touching it in front of your clients, right? You need to cover your nose. That is essential. I can't emphasize that enough. We need to cover our mouths and our noses. And, as I said, don't be afraid to have a face shield around to help you feel even more protected. And I think we all have to be really clear of what our boundaries are in terms of how we interact with our clients, with our families, with our friends. And we have to kind of draw a line in the sand and say, you have to do an individual risk assessment and decide how risky is it for you to be exposed to COVID-19 and act accordingly. So the way I interact with patients in the hospital is with a face mask and a face shield at all times. And the way I demonstrate that as well is I do not touch my face mask. I do not touch my face shield in front of the patient. So I think if we are able to do that in front of our clients and we ask them to do the same, to wear a face covering, I'm not saying they have to wear a face shield. If there's one barrier in between you and them, that's good enough. But asking them to wear their face covering, over their nose properly is the right way for us to prevent transmission and for us to end the pandemic.
So I have two more questions because just sort of conscious of time. One is probably a quick one, but someone had asked in relation to herd immunity, when you're looking at that number, what that 70% was, you said, is it people who have been COVID positive as well as those who've had the vaccine? So would people add those two numbers together, or is it just solely based sort of really on vaccine?
Yeah, good question. So the way that we are looking at it, and like the way that I was looking at it in this particular slide, is we are really talking about vaccinations because we are there are different levels of immune response that our bodies produce based on how severe our infection is. So just because somebody down the street had the virus 4 months ago, that doesn't mean that they're necessarily immunized today. So we do think that the vaccine allows us to feel more comfortable with this immunity threshold for a larger group of people. So if you look at the guidance though from CDC, if you have had the virus yourself within the last 3 months, they're asking you to wait till after the 90 days before you get the vaccination. And that's mostly because of the fact that you probably already have antibodies that are circulating, and B, because we have a limited supply at the moment. So this herd immunity threshold is really, we're talking about vaccinations, because we are not sure after that 3 months after infection, we're not sure where people are on this immunity curve. And we'd like them to get vaccinated to achieve herd immunity.
Cool. Then I suppose the last thing, well, before I get to the last little question, just in case people have to drop off when it gets to 5, we will be holding more town halls, develop a survey just to get a sense of where people's knowledge is and what they would like to learn about through these town halls, because there's so much and there's so many great questions coming in on the chat that I haven't been able to get to, and I apologize, but we will list them and we'll try to get answers out to everyone who participated today. But I have a host of questions I didn't get to as well. So expect a survey coming out from us in the next week. And if you could share it with your colleagues, we'd really like their input. When we have future town halls, if you could spread the word, because the more people who can participate in these discussions, the better in my mind. And yes, we will, and we'll work to get the slides out to folks as well. But the last question or area I had, and it's one that I really relate to, is you mentioned that we are really now at the worst in the New York City area by numbers, even much more so than March and April. Yet March, April, perhaps because everything was so new to us, there was a panic. We locked down, we shut everything down, our workforce shifted gears and stuff. And yet we don't see that now. And we see this almost operationalized as normal as possible. And it makes you almost lulls you perhaps into a false sense of security. Hey, that things aren't so bad, the vaccine's rolling out. And I suppose the questioner is asking, like, how do you, so in the workforce, sort of respond to that? How do you manage your own risk in your own life when what you're saying, it's pretty clear things are actually a lot worse than they were 9 months ago?
Right. Yeah, I think pandemic fatigue is something that we definitely are seeing. And I think if you come back to that image of Swiss cheese in your mind, the way I approach this is when I see the numbers are going up in my area where I live, in different communities across the country, I think, how can I layer more of those slices of Swiss cheese so that the virus is not as transmittable, right? How can I do that? And I just want to bring this up. This is a colleague of mine who is at Harvard, but is based in, who has a lot of family and friends in LA. And Los Angeles is having, as you know, a huge spike and surge at the moment. And their hospitals are extremely full, very similar to what you all experienced in last spring. And one of the things that is coming up is that as high-risk workers, as people that are in the grocery stores, that are out taking care of clients as patients, when we're in the middle of a surge, it might make sense to wear a face mask in your home so that if you have it, you don't transmit it to other people in your household. So I'm just offering, I'm not saying you must do it. I'm just saying that when we're in the middle of a surge, how can you look at your own behaviors and see how you can improve them and do better than you were doing a few weeks ago, right? I think that's important. And then the other thing is to think about this concept of doing an individual risk assessment. So you mentioned this, Mark. Who's in your bubble, right? who's in your exposure circle. So we're advocating as a team, we're advocating for people to sit down and look at everyone who they're exposed to, and then also look at who is at the highest risk of a poor outcome, right? Is it your mother that lives with you, who's older, who has diabetes and hypertension? And then everyone in that circle, in that exposure circle, should agree to the same behaviors, right? So family members, childcare providers, like you all have to agree that we're going to interact with the world in this way. And that is to protect the people in our exposure circle that are at the highest risk of poor outcomes. And then we have these activity risk assessment tools, right? So they help us figure out which activities are low risk, which activities are high risk. And I would just say, taking all this into account, and the fact that numbers are high, and the fact that our healthcare systems are busting, how can we all do better in this moment? How can we do better in this moment so that we prevent our loved ones from getting it and prevent our communities from having too many cases?
You know, I could go on, and I'm conscious it's 5 o'clock, so I really just want to extend my thanks to you for bringing your knowledge here today, for being patient with all these questions and me jumping all over the place. It's been a really interesting discussion, and I would like to thank those who participated. You know, I run trainings from time to time, but I haven't seen this level of chat. And I apologize for not getting to all your questions, but we will make a list of them and make a point of getting responses to them. But as I said, we will be submitting or sending out a survey to those who participated. If you could respond to that, we'll be able to really tailor our next town hall, the doctor and her team, to meet the needs of you as our frontline workers. So thank you so much, and have a good evening.